Welcome to the weekly Neurology Deep Dive. This program is produced by Amer Gavanini.
Right, and just a note up front.
Oh, yes, of course, the disclaimers. So this deep dive is for educational purposes only. I mean, there is no commercial goal here whatsoever. It is strictly a summary of the data, and neurologists listening are highly recommended to read the full paper.
Absolutely. You really need to read the full paper to fully inform your clinical decisions.
Exactly. So today we are evaluating a paper titled Neuropsychiatric Adverse Events with Anti-Seizure Medications in Patients with Epilepsy, a systematic review and meta-analysis.
Right.
And this paper was authored by Kumar and colleagues, and it was published in Epilepsy Research in July 2026.
So, our mission today is to strictly evaluate the data regarding the occurrence of neuropsychiatric adverse events associated with different generations of anti-seizure medications.
And just to give a practical summary right off the bat for clinicians who are, short on time, what is the bottom line here?
Well, while anti-seizure medications are obviously the cornerstone of epilepsy treatment, their neuropsychiatric risk profiles vary significantly by generation and by individual drug.
Right.
So first-generation medications show a higher occurrence of memory impairments, but then certain newer third-generation medications, particularly levetiracetam and topiramate, demonstrate stronger associations with mood disorders, behavioral issues, and psychosis.
Wow, so neurologists really must factor these distinct psychiatric profiles into their initial drug selection then.
Exactly. I mean, they have to implement routine psychiatric screening. It is essential.
That introduces a really fascinating clinical paradox because we often assume that newer, later generation treatments automatically offer superior safety profiles across the board.
Right. That is the general assumption.
But this paper suggests we are sort of trading one set of neurological side effects for another, more psychiatric set. So to properly interpret these clinical risks, we must first examine the scale and the methodology of the data.
We definitely need to look at the numbers.
Yeah. So we are looking at a systematic review and meta-analysis comprising 18 observational studies. That includes retrospective cohort, prospective cohort, case control, and cross-sectional designs.
And the scale of this data is, well, it is precisely what makes the findings so relevant. The analysis encompasses over 5 million patients.
Specifically, 5,151,367, to be exact.
Which is a massive data set.
It really is. And looking at the demographics, the population is about 51% female. The vast majority of the studies focus on adult populations, with mean ages ranging from 26 to 46 years.
Right.
Oh, and there is only one study in there evaluating a pediatric population.
Yeah, and for the inclusion criteria, they looked at patients diagnosed with epilepsy receiving anti-seizure medications compared to either non-users or active controls.
And what were the specific outcome measures?
The outcomes were categorized into 5 domains, so behavioral, cognitive, mood, sleep, and psychotic disorders.
Okay, but I have a question here about the reliance on strictly observational data. Given the lack of randomized controlled trials for these specific adverse events, how does that affect the generalizability of these findings for a neurologist's daily practice?
Well, it is a significant factor. We have to strongly consider residual confounding and confounding by indication.
Because a prescribing neurologist does not assign drugs randomly.
Exactly. I mean, confounding by indication is the primary limitation here. A neurologist naturally avoids giving specific anti-seizure medications to patients with a known psychiatric history.
Right.
Or conversely, they might purposefully select a medication with mood-stabilizing properties for a patient presenting with a comorbid psychiatric condition. So you cannot perfectly control for that.
So moving from the broad methodology to the specific clinical domains, we should first examine cognitive and memory impairments.
Which are among the most frequent daily complaints reported by patients.
Definitely. And the data here shows distinct memory disorder occurrence rates across the medication generations. So about 9% of participants receiving first-generation medications reported memory disorders.
Which includes drugs like phenobarbital, phenytoin, and primidone.
Right. But then that drops down to about 4% for second-generation medications, like carbamazepine and valproic acid.
Yeah, but then it rises again to about 6% for third-generation medications.
So what explains that trajectory, dropping from about 9% to about 4% and then rising back up to about 6%?
Well, it is deeply tied to the pharmacological mechanisms. Older first-generation medications impair cognitive performance through very widespread, non-selective effects on neuronal excitability.
Right, broad suppression.
Exactly. It slows cognitive processing and affects memory retention. Newer medications have greater pharmacological selectivity, but they still present significant cognitive trade-offs.
Because they still alter that neuropsychiatric homeostasis required for normal function.
Right, exactly.
So does this data indicate that the second-generation medications represent a sort of sweet spot for cognitive preservation? Or does the categorization by generation artificially mask the varying cognitive risks of the individual medications within those groups?
Oh, it absolutely masks the varying risks. Categorizing strictly by generation is based on regulatory approval timelines, not on pharmacological or clinical homogeneity.
That makes total sense.
Yeah, anti-seizure medications within the exact same generation differ substantially in their mechanisms of action and adverse effect profiles. So neurologists must evaluate the cognitive safety profile on an individual drug basis.
Okay, so while memory impairment shows that generational trend, the data reveals a uniquely different distribution when examining emotional dysregulation.
Yes, the focus shifts heavily onto the third-generation medications here.
Right, because the depression occurrence data is about 2% for first generation, about 1% for second generation, and it goes up to about 3% for third generation medications.
And we really have to look at the specific, highly relevant data regarding levetiracetam because it heavily drives those statistical trends.
Yes, the paper highlights that in one multinational cohort, anxiety occurred in about 16% of participants on levetiracetam.
Which is a substantial number.
It is huge, especially compared to about 5% for those on lamotrigine, carbamazepine, or oxcarbazepine.
Right.
Furthermore, depression was reported in about 3% of levetiracetam users versus about 0% in the comparative group.
And the mechanisms there, well, they are heavily debated, but they are likely linked to the modulation of glutamatergic signaling and synaptic vesicle protein 2A pathways by levetiracetam.
Which relates to the irritability and mood lability in susceptible individuals.
Exactly. We also see other individual outliers. For instance, clonazepam showed substantially increased odds for depression with an odds ratio of about 14.
Wait, really? About 14?
Yes, whereas valproic acid was associated with lower odds for depression.
So how should a neurologist weigh the excellent seizure control and lack of drug interactions of levetiracetam against an anxiety rate of about 16%? I mean, particularly in patients with baseline psychiatric comorbidities.
Neurologists must implement a rigorous risk stratification protocol. The excellent pharmacokinetic profile of levetiracetam is highly appealing, but this clinical efficacy must be continuously balanced against the patient's psychiatric history.
They need to prioritize routine psychiatric screening before initiating it then.
Exactly. And maintain close clinical monitoring throughout the treatment course.
So beyond mood and behavioral shifts, the paper also analyzes the most severe neuropsychiatric adverse events, psychosis and suicidality.
Which naturally carry the absolute highest stakes for patient safety.
Right. The meta-analysis findings regarding psychotic disorders showed that there was no significant difference in psychosis risk between first-generation and second-generation medications.
And the risk comparison between second-generation and third-generation medications was also not significant.
But again, does grouping the data dilute the severity of the individual drug profiles here?
It absolutely does, because when you look at specific medications, topiramate demonstrated the strongest association with psychosis, showing an odds ratio of about 3.
And what about the older drugs?
Phenobarbital, phenytoin, and zonisamide also showed elevated odds. The mechanism likely involves alterations in dopaminergic and gamma-aminobutyric acid pathways.
Right, disrupting the cortical networks.
Exactly.
The paper also rigorously addresses suicidality. Levetiracetam was notably associated with higher odds of suicidality in one nested case control study, showing an odds ratio of about 6.
Which, again, requires very meticulous clinical interpretation.
Well, this brings up an important point. Following the 2008 regulatory warnings treating suicidality as a class-wide risk for all anti-seizure medications, does this paper provide enough evidence for neurologists to stratify these severe psychiatric risks on a strictly drug-by-drug basis, rather than viewing it as a uniform class effect?
I would argue that it strongly suggests that stratifying these severe risks on a strictly drug-by-drug basis is the most clinically sound approach.
Because the risk is not uniform.
Right. It is absolutely not uniform. The distinct odds ratios seen with levetiracetam and topiramate compared to other agents suggest that individual drug characteristics dictate the actual risk.
So treating these adverse events as a uniform class effect just oversimplifies the clinical reality.
Exactly.
Okay, so to bring this all together, what is the practical summary for daily clinical practice that we can leave the listeners with?
Well, the overarching point is that the risk of neuropsychiatric adverse events is not uniform. First-generation anti-seizure medications present the highest burden for memory impairment,
Right.
while third-generation agents, notably levetiracetam and topiramate, present the most significant risks for mood disorders, behavioral disturbances, and psychosis.
Meaning neurologists must prioritize routine psychiatric screening and really individualize therapy.
Absolutely, particularly for patients with a pre-existing psychiatric history.
Well, that leaves us with a final, somewhat provocative thought to ponder for you listening today. If the psychiatric side effect profile of an anti-seizure medication is as highly distinct and specific as its efficacy profile for controlling specific seizure types, should future clinical guidelines weigh a patient's psychiatric history equally with their seizure semiology when making that crucial first-line drug choice?